Assalamualaikum warahmatullahi wabarakatuh and good morning to all. Welcome to another session of Breakfast at Health. It's actually the 33rd session. It's a weekly talk by experts at the Faculty of Medicine, Dentistry, Pharmacy on interesting and important topics related to health and wellness. Today's topic, I would argue, is an important topic for health professionals practicing in the 21st century. The title of today's talk is Health Misinformation During COVID-19, the Role of Researchers and Clinicians. The COVID-19 pandemic exposed the importance of health information, its dissemination, how we get the message across, beginning from the beginning of the pandemic to the effort in trying to get people to take vaccines. But it also exposed the dangers of misinformation and disinformation. Our speaker, Associate Professor Dr. Adam Dunn, happens to be an expert in this area. Adam is currently the head of department for the Department of Biomedical Informatics and Digital Health at the Faculty of Medicine and Health at University of Sydney. His research is about applying data science and machine learning in clinical epidemiology, aiming to improve the overall use of clinical trials evidence in systematic reviews and clinical practice, as well as on ways to improve health behaviours by monitoring how evidence and misinformation are taken up by different communities. He has led projects funded by the NHMRC, Australia, AHRQ, NLM, NIH, as well as WHO. He is currently the convener of the Digital Health and Informatics Network at the University of Sydney. So without further ado, I would like to introduce Adam. Adam, the mic is yours.
Thank you very much. Thank you, Adina, for the very, very nice long welcome and introduction. I'm going to attempt to start to share my slides. So bear with me just for 1 minute as I do that. All right, so hopefully everybody can see me just fine. As you heard, my name's Adam Dunn. I've been working in areas related to misinformation for nearly a decade now, but mostly on studies that make use of large sets of data from social media. And as you heard, I work largely in applications of machine learning in health and data science. And so today there's going to be a bit of a flavor of large-scale data sets in the discussion about health misinformation during COVID-19. And I'm also hopefully going to leave you with a few ideas or a few lessons on what we think about health misinformation and how it spreads and what we can do as well. Okay, so often when we start seminars and lectures in medicine, we're asked to disclose any conflicts of interest. I've included mine here, but I also think that these conflicts of interest or declarations of the things that I do can help give you an idea of the kind of areas that I've been working on for a long time. So while you read through those, what I'm going to do is explain what I'm going to do in the next sort of 45 minutes so we have plenty of time for questions. First, I'm going to start with some definitions of misinformation. I'm going to start with a simple example that I'm hoping to get your input on. Then I'm going to go through some examples that you might remember from during COVID-19 and examples that often came from research. I'm then going to talk about the state of misinformation research, some of the reasons why the work that we do in the area in the world isn't currently very useful for helping governments and public health organizations and social media platforms and doctors or the community. I'm going to end with some work that my teams have done to try and fix the way we deal with misinformation in the community and measure it, and in ways that we hope are going to be more useful in the future. All right, so let's start with some basic definitions. And the reason why I think these are important is because in what follows, I'm going to talk about misinformation, and I'm also going to mix in examples that are related to things like vaccine critical content, anti-vaccine advocacy, conspiracy theories and myths. And they're not at all the same thing. They can be quite different. So I think the key things to remember today are that misinformation is still misinformation, even if it's unintentional. And when the person who's spreading it doesn't really intend to deceive anyone. Conspiracy theories are always related to the belief that someone powerful or an organization that's powerful is covering up a secret deliberately. And just because someone is critical of the status quo doesn't mean that they're necessarily spreading misinformation, because evidence can change over time. And it's quite possible to say something that is both completely true, but also harmful. Okay, so this is where I want some input, and I'm hoping that you're going to be able to type into chat what you think the answer to this question is. So here's an example of 4 food items, and it's 100 grams of kimchi, 100 grams of dark chocolate, 100 grams of chickpeas, or 100 grams of cooked spinach, which is probably like, you know, giant packets of cooked spinach because it shrinks down to nothing when you cook it. So the question is, which of these foods have the most iron? And what I want you to do is to type into chat which of the foods you think has the most iron in it. So can the participants type into chat? Perhaps not. Perhaps it's not possible for the participants to type into chat. Unlucky. You'll just have to imagine it in your head, whether or not you think it's kimchi, dark chocolate, chickpeas, and cooked spinach. And I don't know about you, but in Australia,
hang on. I think they're trying to able to chat.
Okay, no worries. If we can, we can. And what I'll do is I'll stall and tell a little story about this one. But
I think they can write in the question section.
Oh, we don't want to clog up the question section too much.
Oh, okay.
That'll be too difficult. Yeah. Thanks for the 2 people who said the chat's disabled. No problem at all. We'll keep going. Yeah.
Okay.
So out of these 4, often when I ask this question for undergraduate students, when I teach about this area, they often say spinach. And the reason why they say spinach is because there's this idea that spinach is a really good source of iron for people who don't eat meat, for vegetarians. And the reality, of course, is that's not true. And you probably guessed before I started that this was going to be a bit of a trick question. So it turns out that the 2 sources of the 2 foods on this page that have the most iron are dark chocolate and chickpeas, and spinach and kimchi are about the same and are much lower. And the reason why this is actually kind of a myth or misinformation is because apparently, many years ago, someone was measuring how much iron there was in spinach and made a mistake. They actually made an order of magnitude mistake and just moved the decimal place across one place and assumed that it was 10 times the amount of iron that was available in cooked spinach for your diet. And it turns out that actually even that information might not be true either, because someone actually went back and tried to look at the origin of this particular myth about the change in decimal places. And it turns out they couldn't find any evidence of that either. So we actually don't know. We know that spinach has less iron, but we don't know what the origin of that was. And for those of you who might remember, there was a cartoon called Popeye, where Popeye would eat spinach as a source of energy and strength. And that played a kind of a significant role in how this myth became popular over time as well. And so that's really an example of misinformation, that people believe that spinach is a really good source of bioavailable iron in your diet, and more so than many of these other foods. So that's one example of misinformation. And I wanted to use that example because it's not really necessarily a terrible one or a harmful one, but it's certainly an example of misinformation that has spread around the world for quite a long time. All right. So now let's start with some examples of misinformation from COVID-19. And I suspect that you might know about some of these or remember some of these. So the first one I wanted to talk about was hydroxychloroquine. So hydroxychloroquine was touted as a way to treat COVID-19. And it was spread very quickly. And we know that it spread around the world, and we know that it had an impact because there are stories about people who fatally poisoned themselves while trying to take hydroxychloroquine. So there's this quite sad story about a couple in Arizona who identified chloroquine in a fish tank cleaning additive. And so they ingested it, and the man died. And that was very early when hydroxychloroquine chloroquine was being advertised or promoted at some very high levels as a treatment for COVID-19. The other thing that happened in that time is that there were researchers, kind of like us, could be from the Faculty of Medicine in different places around the world, who were studying hydroxychloroquine. And there was an example of a particularly senior person in the area named Didier Rael, who published some retrospective analyses. And the studies were flawed, and he had some trouble as a consequence of publishing these ones. I actually think the journal bared some responsibility as well. And those studies were then cited quite heavily as evidence for hydroxychloroquine, and were part of the things that people would talk about in terms of the the value of these drugs in treatment of COVID-19 and the problems that ensued afterwards. Even in Australia, where I come from, we aren't immune from this. And there was a study that continued to test hydroxychloroquine well after the WHO recommended that hydroxychloroquine trials were paused. So we can see that this was a study and we can look at the registration, and that registration is trial registration. So when you want to start a trial, you have to register the trial. And in this case, it was registered with the trial registry called ANZ-CTR, which is the Australian New Zealand Clinical Trial Registry. And they removed the drug from their trial, which is a trial that tested many interventions in 12th of November 2020. But that was well after the WHO pause. Turns out we didn't actually learn our lessons from the spread of misinformation about hydroxychloroquine. And people were not necessarily intending to deceive with hydroxychloroquine. They really believed in it. But we didn't learn our lessons. And then another drug called ivermectin was also tested and had had positive results in an Australian trial. And in the communications about the value of this drug, they didn't include the limitations, and they weren't very clear about how they did it. And they were attempting to promote this as a drug that was going to be useful for treating COVID-19. We now know, of course, that neither of these drugs are particularly useful for treating COVID-19. And the spread of misinformation in these cases has caused some issues. Let's have a look at another example of COVID-19 misinformation. So you might recognize this picture, or you might recognize where this picture might come from. And this picture at the bottom is actually the wet market in China, where the origins of COVID-19 or the coronavirus were believed to have started. This is another example of where research can cause a problem, where researchers have actually been may have been partially responsible for the spread of misinformation. This is an example of a preprint. So this is not a published article. It's just basically what we would think of as a draft of an article. And it was uploaded on the 31st of January 2020. It's very soon after the structure of the virus was known and made publicly available. And this group of researchers, they used bioinformatics techniques, and they just ran the structure of the virus through something called BLAST. And what they discovered was that there was a match between some parts of the virus structure and some other examples. And in this case, they talk about HIV. In the quotation from the article says, our results highlight an astonishing relation between GP120 and the GAG protein of HIV. And of course, that relation was actually not astonishing at all. And it's actually extremely common to find copies of sequences across different kinds of viruses. And it shouldn't have been published. It shouldn't have been uploaded. And what happened was that they actually very quickly removed it. They retracted it, and they withdrew it within a few days, actually. And so they recognized that there was a problem with the methods that they used in the study or in the analysis, and then removed it. But the fact that I'd already written an astonishing relation and an uncanny similarity of novel inserts is unlikely to be fortuitous. And what happened was that a right-wing media outlet called Zero Hedge grabbed hold of this preprint. I found this preprint and started to write stories on the this astonishing relation. And so what they were suggesting as part of the article was that this was created in a lab. And the problem was that the news media, especially starting from the kind of extreme right-wing news media, then took hold of this story and started posting it more and more and more. And it became this incredibly powerful piece of misinformation that should never have been put online or published in the first place, and obviously created harm. And I would argue that it also led to increased racism in countries around the world, because it was giving people an excuse to be racist by accusing China of creating the virus in a lab. And so that's another example where the misinformation probably led to harm or helped to catalyze harm in the community as well. So those two examples of COVID-19. What I wanted to do now was to talk a little bit about misinformation research. So in the last two examples, we see that we have a problem with the research, the basic research that people do being misinterpreted and then miscommunicated in the public domain. But we also have problems with the misinformation research that's happening right now. So teams with experience in very specific areas manage to publish studies that people don't read properly and just assume the conclusions are correct and appropriate. Well, I'll use examples of research from vaccination generally, because that's an area that I focus on quite a lot. So on the left, we have an example of an article that was published in the American Journal of Public Health in 2018. It already has 826 citations, and it was featured in well over 200, 300 news articles. And what they conclude in that article is that bots and trolls are eroding public consensus on vaccination. But the problem is they don't actually measure this at all. So they use a biased sample of tweets and they compare it to another biased sample of tweets from Twitter. And they never measure whether those tweets are actually seen by people or if they have the potential to have any impact on public consensus. So my team have since shown that these kinds of tweets are extremely rare to see and that this conclusion is unfounded. And I'll show you that in a little while. But on the right, we have something that's quite similar. So this was a paper that was published in Nature. It samples Facebook groups that are explicitly about vaccination. So across a relatively tiny number of vaccine-specific groups, just hundreds of them, which is with what is kind of a tiny proportion of Facebook users. And what they did is they excluded mainstream news, public health organizations, celebrities. They excluded all of those from the analysis because they weren't vaccination-specific groups. They then claimed that anti-vaccination views will dominate in a decade. What they never did, they never measured people's views. They just compared the people who joined vaccination-specific pages on Facebook to people who joined other vaccination-specific pages. It wasn't representative of any population, and it never actually measured their views. So both of these studies generated thousands of news articles where the bad conclusions were passed on. And the thing they have in common is that they sample from social media data badly, and they make claims about what people believe and do in the real world, without actually connecting the data to reliable outcome measures about attitudes, behaviours, and health outcomes. And we'll come back to this again later in the talk. But the thing to remember about this one is that the studies they did were just on the data, and they didn't connect to what people actually believe and what people actually do. Okay, so this is a few years after that work was published in the American Journal of Public Health. We wanted to actually check whether people were likely to see posts from bots or to see vaccine critical information on Twitter at all. What we found was quite obvious, that just 6% of a random sample of Twitter users just from the United States see more vaccine critical information than they see neutral or positive vaccination information. And they almost never see tweets posted by bots. So the potential for bots and trolls to have a direct impact on people's attitudes and behaviours is negligible, and it can only be negligible because they very rarely, if ever, see posts from bots. This was a big team effort, and I'll name these people here because you'll see their pictures on later slides as well. This is Paige Martin, a software engineer. Didi Suryan is a postdoc in machine learning, Emily Dida, who's an epidemiologist who used to work on the ground in public health in Australia, Jason Dalmazzo, who's another software engineer, and Marika Steffens, who was a journalist and finished a PhD in communications and an area related to social psychology related to vaccination. And the reason why I wanted to post about these ones is related to the next thing on the next slide. So if it isn't obvious based on the list of people on the previous slide, I think that the key to solving the issue with problems in misinformation is about multidisciplinary research. So exactly the kind of research that people in digital health are good at. So in the previous slides, I showed you examples of studies that only examine content and group membership that sit on the very far left over here. On the very far right in blue, we have this kind of vast literature from social psychology and from health behaviours and communications. But these studies are often done in smaller cohorts of participants. They're done as trials, and they're done in isolation from the online environments people live in and the communities that they seek to join and belong to. So only a handful of studies manage to connect across this complete spectrum between social media and web data that we can access, through to who sees that content, through to the ways that they engage with that content, and then through to the proper health outcome measures that we can collect outside of social media through surveys and questionnaires and in some cases even electronic medical records. Okay, so people often ask me why misinformation spreads, or how misinformation spreads, or why do people believe misinformation and how does it affect their attitudes? And we know that misinformation can spread and can cause harm. You know, we've talked about 2 examples of that already this morning. But it can be really hard to predict what kinds of misinformation are more likely to spread. And it often seems random about which things are going to take hold and which things are going to influence people. And I tend to always give the same answer to this question. I think that a major factor that contributes to not only the spread of misinformation, but the potential for it to influence behaviours is about communities. People want to belong to communities, and they're likely to follow along with the prevailing attitudes in the communities that they belong to. So in a study my team did many years ago now, we looked at the concentration of certain topics within communities. In this case, we were using tweets about HPV vaccines, as well as the follower connections on Twitter between the users who posted about HPV vaccines. And so if you don't know, HPV vaccines are human papillomavirus vaccines given to teenagers before they become sexually active. And Australia was one of the first places where HPV vaccines were rolled out because one of the HPV vaccines was created or developed or invented in Australia. So in this case, what we did was to apply 2 methods. One was called topic modelling, which finds natural groups across tweets based on the language that's used within them. And one's called community structure analysis, which finds natural groupings between users based on the follower connections between them. So we tested the topics to understand how different they were from each other, and we used the ability to differentiate between them manually. So we actually had people looking at the tweets that belong to certain topics and see if they could pull out and tell which one was different if it came from a different topic. And we use that to create this hierarchy of topics. And so you won't be able to read the text in this picture, but in red are vaccine critical topics such as scandals, conspiracies, side effects, harms, and so on. In blue, we have experiential posts from teenagers who discussed going to get their HPV vaccines. And in green, these are informational ones and pro-vaccine tweets that include things like news media, information on how and where to get the vaccine, as well as research in the area about the efficacy and safety of HPV vaccines. We then looked at the distribution of tweets from those topics across the communities that we extracted based on the follower networks. And you probably won't be surprised to see that the communities don't mix very well across the green, the red, or the blue. And on the right, you should be able to see an example of a community that posted mostly in red topics. There's a community who posted mostly in green. But I think the most interesting one is the teenagers, and they're kind of beside my head here, who posted about their experiences. And they almost never engaged in posts related to either green or red. And I think this can tell us something about how well our public health advocacy works and who it targets. It tells me that the people who were posting about getting HPV vaccines were not at all engaging in pro-vaccine or anti-vaccine rhetoric. on Twitter. They just weren't engaging with it at all because they didn't belong to the communities where that information was spreading. Okay, so as I mentioned at the start, I'm also going to be talking not just about misinformation, but also about conspiracy theories. And obviously, there's quite a big overlap between misinformation and conspiracy theories. But I wanted to show you this example because I think it's an important one in terms of how we measure and how we look at online information to try and understand what people believe and how they like to belong to communities. And so I think this one tells us quite a bit about how belonging to a community becomes an important part of how misinformation, conspiracy theories can spread, and how we think it might influence attitudes and beliefs beyond just what people post and talk about online. So in this study, we looked at data from Reddit users. And so we sampled users who posted and commented on what's called the conspiracy subreddit. And I'll call this conspiracy subreddit r/conspiracy because that's how it's sort of labeled. And so for the people who posted in conspiracy subreddit, we were pretty confident that they were engaging in conspiratorial thinking and the conspiracy community. And so they're engaging in this community where people were talking about conspiracy theories. So in this study, we wanted to look at what makes these users different from other users in terms of the language they use and also where they post. The problem is that there might be unmeasurable things about people who post in our conspiracy compared to the average Reddit user in terms of things like age, gender, topics of interest, how often they post, which country they come from, those sorts of things. And we can't reliably estimate all of that information directly from a username or from the content that they post. And so to deal with that, what we used was called a matched pairs analysis. And so what we did is we go back from 6 months before a user first posted in our conspiracy and create a timeline of all the posts and comments they made anywhere on Reddit. And then what we do is we find another user who posted in the same first subreddit at about the same time, and then posted nearly as often as the user who went on to post in our conspiracy, but never did. So they had pathways that went in different directions, but they posted about the same time and they started in the same place. That way, we're comparing oranges with oranges, rather than trying to compare within a set of different oranges by sampling from sort of the entire fruit basket. What we found was a really complicated set of differences in the kinds of language that people used and the pathways through which they would reach our conspiracy. So in the example here on the bottom left, you might not be able to read the text on this one or the numbers. This is a visualization that I created that shows our conspiracy users at the top and how often they jump from subreddit to subreddit on topics, in this case, related to guns and gun rights. And so we had tens of thousands of different subreddits in this analysis. And I've just pulled out some examples from guns and gun rights and showed you the pathways through which people traveled to reach our conspiracy. And so you can see, compared to the other users on the bottom, these users on the bottom were much less likely to follow that trajectory to our conspiracy. And so while there were roughly equal numbers of users who were posting and commenting on things like archery and hunting, users who would eventually find their community in our conspiracy were much more likely to post and comment in guns are cool, AR-15, firearms, gun politics, and pro-gun. And so I think the interesting thing here is about why the users managed to end up in our conspiracy after following this pathway, and why the users at the bottom didn't end up in our conspiracy and didn't follow this pathway. And what we found was actually the language that was used was actually quite different between those kinds of users as well. So even though they posted about the same amount of times and they commented about the same amount of times, there was a much different focus on the content of the things that were being posted by those people who traveled through those subreddits to eventually start posting often in our conspiracy, and who we are reasonably confident were engaging in conspiratorial thinking. So this is a really interesting one. It means that we're able to access lots and lots of data. And I showed you in the previous slide, we're actually accessing hundreds of thousands of tweets and billions of social connections between people. And in this case, we had tens of thousands of subreddits and tens of thousands of users that contributed to these data sets. But one of the things that's kind of harder to do is to recruit people into studies. And I'll talk a little bit about this later to show you how, in order to actually capture those health outcomes, those real outcomes that we really want to capture, it can be a little bit harder. So here's another example of a large data study that we undertook. in this area. So this work actually predates the two studies I showed you with the kind of the problematic conclusions that I described at the start of the talk. But unfortunately, this one doesn't get as many citations or news articles. And the reason why is because we don't claim some scary conclusions. And we use some, I think, interesting and more robust methods of sampling and linking to real outcomes. But of course, we don't produce the kinds of scary conclusions that the other ones do. So this example is actually from 2017, and we extracted two kinds of data from Twitter. The first was every tweet that mentioned anything about HPV vaccines over a couple of years. And the second was a random sample of around 50,000 active Twitter users who had enough information for us to be able to locate them at the state or county level in the United States. The key difference here is that we weren't sampling tweets and assuming they represented a population's views. We actually sampled users who were likely to be accounts of real people and may or may not have ever posted anything about vaccination at all. And so back then, this kind of sampling required us setting up machines to constantly monitor and save tweets over the 2-year period. These days, the Twitter API actually makes this much, much easier for academics to do research in the area. So if you're interested, this kind of study is now much easier to do. So we had this nice sample of 50,000 people in the United States, and we knew approximately where they lived. And so the next step was to examine the accounts they followed. And then we used what was literally billions of follower connections to map out which tweets people in each state in the US were more likely to be exposed to, which HPV vaccine tweets they were more likely to be exposed to. We then used an unsupervised machine learning method called topic modeling, which I described before, to group the tweets into a set of about 30 different topics. And we use differences in that topic exposure at the state level to model state-level HPV vaccine coverage in teens. And what we found was that states that had lower rates of HPV vaccine coverage were also the same states where vaccine critical topics, and remember, these are not necessarily misinformation, they're vaccine critical topics, more heavily featured in the information diets of the Twitter users who were sampled from those states. This is kind of ecological study design. So we also showed that models that accounted for information exposure were better at modeling vaccine coverage than things like insurance, education levels, income, and so on. So as I mentioned, this is kind of ecological study design, where what we do is we compare a population level measure with a population level measure. What we don't have is individual measures or individual connections between those individual users as inputs to match those outcomes. And this is kind of a limitation of the study design because we're constrained in types of conclusions that we can draw. And we can only talk about correlations. But, and let me take a drink. This was a huge amount of work. It was an extremely large set of data. And because it connected to real world outcomes, I think, personally, because I did the study, I think it should have been much more important than the bots and the trolls and the Facebook studies that came later. I'm hoping that more and more studies in the future will copy these methods. And if you want to ask me later, you can ask me about the study that was published in Science that actually did use these methods quite directly to measure things about voters in the United States, but didn't cite us, unfortunately. Okay, so introducing you to one more person, as Zubair Shah. Zubair now works overseas as an assistant professor, but was also a postdoc in my group, and you've seen a picture of Jason Dalmazo before. So we didn't just do research that was aimed at trying to measure the size of the problem and trying to find out where and how things spread, but we also attempted to develop methods that we could then translate into as tools to try and fix the problem too. And so for the rest of this seminar today, I'm actually just going to be talking about the kinds of things that we do to try and fix these problems and the things that we can do for public health organizations, for social media platforms, or for clinicians to try and address the problem of misinformation and its impact on behaviours. And so this particular example, while you might not be able to read the text or see the graphs in any detail, I'll summarize for you what they're talking about here, or what we did. So this is an example where we mined hundreds of thousands of web pages that included information about vaccination. And so we used links to web pages that were posted on social media, and we extracted the text from all these web pages and then used machine learning, specifically natural language processing, to try and classify the pages according to 7 or so measures of credibility. And then we evaluated those classifiers to see how well they could predict the overall credibility score of a page. And so, of course, a web page that had a high credibility score was much more likely to be a fair representation of high quality current evidence. And a web page with a low credibility score was much more likely to include misinformation and to have things that were not based in evidence or were misconstrued or changed around in order to try and get their message across. And so obviously low credibility pages were often anti-vaccine pages as well. And so the performance of the classifiers that we built using machine learning, natural language processing, were pretty good. And so the idea that we had here was that it could be used by social media platforms to flag links that were about to send you to a low credibility or a high credibility web page as a form of pre-bunking. And so, for example, if there was a link to a predicted low credibility page, that's where a social media platform could, for example, warn people immediately before they see something to sort of debunk that content. And that way, hopefully, the people who then go and click on it or don't click on it are less likely to then read it or accept it as a fact. And then it would obviously be less likely to influence their attitudes and behaviors. As this idea that we could use machine learning as part of a pre-bunking tool. So we never did manage to create or deploy this tool, but there is some excellent research happening elsewhere around the world that shows that pre-bunking can be an effective tool to use on social media, and they test these in trials with participants. And also social media platforms have since started flagging posts, and they flag posts and they say, oh, this post, we've hidden it because it might contain controversial information. You have to click on it to open it up. And so it's a kind of form of pre-bunking for them as well. However, in social media platforms today, I still think they're just using keywords from the posts themselves, rather than looking at the content of the page that they're linked to try and pre-bunk for low credibility web pages. So this is Mareka Steffens. Mareka did a PhD in my team and is now a researcher in an organisation attached to the University of Sydney that works between academia and policy. Mareka was a journalist and did a PhD in communications and sort of social psychology related to misinformation. And she was really interested in helping public health organizations manage misinformation on social media. So this is for public health organizations who maintain a Facebook page or are trying to do communication interventions to improve vaccine coverage, for example, or uptake. And so one of her studies was a trial that tested the format of communications that were intended to debunk myths related to vaccination. And her target was vaccination in very young children. And so as I hope you can see on this side, the format varied from stating the myth as the title of the article, posing the myth as a question in the title of the article, or just stating the fact as the title of the article. And what she found was, I don't know, I want to say it's quite boring, but what she found was that all of these actually led to an improvement in the sense that people who were exposed to any of these conditions were less likely to believe the myth, and that continued for a period of time. So not just immediately after they read the article, but a week or two later as well. And the key for this particular study, and the reason why I wanted to highlight it, is that this one was tested in a population of mothers with young children. Where most studies in these kinds of areas, they recruit people rather than focusing on the audience who are currently making decisions about vaccinations for their children, and they'll just look at anybody. And so, for example, in the studies that I showed you previously on using large data sets from social media, we weren't interested in recruiting individual people who were making decisions. We picked people from anywhere. And so people's views or attitudes or behaviors, they might influence people around them, but they weren't necessarily making decisions for themselves about HPV vaccines, for example, or vaccines for their children. They might be making decisions later on, of course, it's before COVID-19, but they might, of course, be making decisions about vaccination for COVID-19 as well. So it's important to think about this in terms of how we recruit participants. And so let me move on to what I think is probably some of the most important work that we're doing now. So this is actually work that we recently started here in Malaysia. And it's a project that was partially funded by the World Health Organization. And in this case, we wanted to individually link social media data from people to proper measures of health behaviors. And in this case, we're looking at adherence to statins in a population of people who are at high cardiovascular risk and for whom statins would be prescribed. And so I wanted to make note of that because if we think about in the previous slide, we're talking about people, young mothers of young children who are thinking about vaccination. And in this case, we're doing this pilot study in a group of people who are at high cardiovascular risk. And that's this key thing about the difference between being able to recruit specifically for the population that we're interested in, rather than trying to access lots and lots of data all at once. So in this case, how do we collect social media data? Well, we're asking participants to collect it for us. And so what they do is they install a smartphone app that lets them record any kind of relevant information they see. And this could be on social media. It could be when they're searching for it online. It could come from their friends, their family, their doctors. It could come from WhatsApp groups. It could come from wherever. And so what we also do is we ask them to tell us if they trust the information each time they record an instance of it in their daily lives. And so in this case, we're asking them about cardiovascular risk, about statins, and about things that are related to whether or not they're likely to take statins and whether or not they're going to continue to take statins. And we measure this kind of information over a month or two. And so the major advantages of this approach are, firstly, well, we think it helps us capture more of the information that's important to people, but also importantly, the information that they trust. And secondly, and most importantly, we're able to individually link the relevant information that comes from their social media or indeed any other source of relevant information to validated survey instruments. So these are examples of questionnaires that have been tested that we know are reliable measures of their attitudes and behaviours. We could even link it to medical records. So eventually, we're hoping to use this information to develop localized risk signatures all around the world, measures of the information environment that are associated with those attitudes and behaviors that are not based in evidence and that may lead to harm. So the major limitations of this kind of approach are obviously the fact that we need to recruit people. So this means that the studies are more expensive and smaller, but also that because we involve participants in the data collection, the process can influence how they interact with information as well as their behaviors. So in our pilot study using these smartphone tools, we discovered that participants were really keen to use these tools to support their healthcare journey. And so they wanted to have control over the history so they could go back through their smartphone app and they could look back at the information later. They could make notes about it. They could take it with them and show it to their doctor. And they really wanted to compare their levels of trust in certain sources of information with experts and with peers. This is a really interesting one because it wasn't designed as a tool to be able to do this, but it's a really important thing because it enables people in the community to make better sense of the information that they see around them in the world and hopefully discuss that with experts. And in this case, those experts might be their doctors. All right, so let's end by talking a little bit about what we can do about misinformation as researchers, as doctors, or as people who might be able to change or implement policy. I just have 3 examples of this. So first, I think as researchers, we can avoid accidentally creating misinformation by having multidisciplinary teams that are genuinely integrated. And this was my first major point about why I think digital health plays such an important role in research, because we are multidisciplinary. We cross lots of different disciplines. I often review papers in computer science where a health professional, often a doctor, has been added to the author list, but it ends up being very clear that they had no input into the paper. Second, in terms of policy and how social media platforms and media are run, I don't think we have time today for a debate about censorship, but with better tools for being able to spot emerging risks, emerging signatures that are likely to be associated with direct harm, social media platforms could downrank their content in their algorithms, or they could identify communities where misinformation often spreads and recommend users and content from other communities where conversations are associated with kind of healthier behaviors and evidence-based content. And social media platforms can absolutely do that, but also people who use social media platforms in sophisticated ways, such as public health organizations and governments, could also push high-quality information and recommend users who are spreading evidence-based content specifically to communities where we identify that there might be potential for harm. Or in our case, it might be teenagers for Hpv vaccines, or it could be any of those things. So third, as clinical professionals, as doctors consulting with patients, there's obviously training that can be done to upskill on how to communicate with patients about misinformation. and about things like medical myths. But I also think it would be nice if there was enough time during our consultations to be able to give patients the tools they need to be able to critically appraise the information that they hear and see. And so I think those are the three things, the three main points that I wanted to really get across in this morning's seminar for how I think we can engage with misinformation better. 1, to stop it spreading. 2, to study it better. And 3, to do the kinds of research and the kinds of studies that will actually lead to positive changes and have impact in the community. And I deliberately sort of stopped on this one because I wanted to plug, my own departments. This is Biomedical, Informatics, and Digital Health. We have around 60 people in the team. So part of them are represented here, and you can see in the background the building behind is called the Anderson Stewart Building, where the School of Medical Sciences is mostly based, but we're all around campus and all of the campuses, the University of Sydney campuses now. Also, I wanted to talk a little bit about the Master of Digital Health and Data Science, which we run jointly between Faculty of Medicine, Health and Engineering, and also the Digital Health Week Conference, which is run between the Digital Health and Informatics Network at the University of Sydney, but also with the University of Melbourne. And we're also bringing along more universities around Australia for Digital Health Week Conference, which is in the beginning of next year. All right, so what I'll do is I'll stop there. I'll quickly show you the list of references that I used in this study. I'll stop sharing and hopefully we can open it up for some questions.
Thank you very much, Adam. That was a very comprehensive journey you took us on, starting from the misinformation that has happened during the COVID-19 and good work on vaccine misinformation as well. We're just waiting for questions. I'm sure there are many people trying to type their question in now. But I just want to start by, there's one question.
I can read that one out and answer it if you like.
Go on, yeah.
Okay. The question was, are there practical tips on how patients and consumers can decide what is good information or not? That's a really good question. So there is lots of work that happens in communications and in places like health literacy, and including in e-health literacy as well. We happen to have an expert sitting kind of right next to me on the video screen in health literacy, and I think that's where I would focus my attention. So yeah, there are practical tips on how patients and consumers can decide what is good information or not. But the challenge, of course, is that it's related to this idea of community. And often people they have the tools that they need to be able to to critically appraise the information that they see online. But because they want to belong to a community, often they can ignore the tools and the skills that they have in critically appraising information just to belong to a particular community. And so there's no simple answer to that. But if you want to be proactive, there are definitely practical tips. I don't have them for you. I'm a computer scientist, but those are definitely around. Okay, should I go for the next question answer? I will.
Yeah, sure, go for it.
Okay, so question from Chinhai: was the analysis of the text done manually by the team, or if NLP is used anywhere? So in the large data sets, we're talking about tens of thousands or hundreds of thousands of tweets or web pages or Reddit posts. And so, yes, absolutely, we did need to use natural language processing to be able to make sense of the posts. And so what I didn't tell you about, because we didn't really have time to go through all of it, was the performance of the machine learning algorithms. Natural language processing is generally done using machine learning these days. The manual aspects of it were, for example, in the construction of the hierarchy, based on being able to tell the difference between things that belong to different topics. And of course, we had to test it by manually annotating a large number of them to start with before we could apply the machine learning algorithms. So the answer is yes and no and yes. The next question is from Alison Chung. Is the Master of Digital Health offering a distance learning course? I think the answer to that is yes. Yes, it is. So the Master of Digital Health and Data Science is available as a distance learning course. However, can I suggest that there also will be a Master of Digital Health available at the University of Malaya. I already know it's going to be a very good one. So if you're interested in doing a master's course in digital health, there's one that's quite close by that you can have a look at, which would be great.
Come to UM.
Indeed. And I can almost guarantee that I might even be invited to come and give some lectures for the Master of Digital Health year as well.
Yeah. There's one more. Yeah.
Yep. So there's a couple of there's a few more questions. There's actually one in the chat. How can message fatigue impact misinformation? That's a really tough question, Shahira. I don't think I can answer that question at all. There is this idea that information overload can cause confusion, and that because people see too much information that they don't know how to trust it. There was this really interesting computational social science study that showed that because people see so much information, it's hard for them to pick out what is high quality. And so they're much more likely to be exposed to, or much more likely to grab onto and read and click on low quality information because of the volume and rate at which information spreads. And that comes down to the way social media platforms are designed as well. Okay, can the same kind of analysis be applied to Facebook? Malaysians are far more active there and on WhatsApp compared to Twitter and Reddit. It's a really good question. I 100% agree. I think Twitter and Reddit are specific to certain countries. Facebook is much more important. Unfortunately, Facebook has made it slightly difficult for academics to do research on Facebook, and the current word on the street is that Facebook may not be as useful for doing academic research through CrowdTangle, which is where you would access data. But I can't really talk about that too much because people from Facebook invite me to fancy dinners and tell me about the policies and things that they're doing. And so I kind of have conflict of interest there. I have never been to a fancy dinner with Facebook, though. However, let me also say very quickly that the last example that we talked about is actually an example where the study is being undertaken here. University of Malaya are undertaking a study where we give people a smartphone app. And actually, this smartphone app allows you to record relevant information that you access very quickly and from anywhere. So the idea is that you have your smartphone app, and if you see something on WhatsApp, you just take a snapshot and post it to your diary, your media use diary. But it might also be a conversation you have with your friend or your doctor. It might come from Facebook. It might come from anywhere. And so I think those kinds of studies where you actually have to recruit people are much more powerful and would encompass Facebook, WhatsApp, and so on, and don't have to rely on data from just one social media platform. A really good question, a really important one as well. Okay.
Adam, before you answer David's question or comment, I think I just want to ask how much will the social media company allow this type of research in the future if they're going to if your findings are going to put their business in jeopardy? Because I think Twitter is under a lot of pressure to censor people after certain studies came out that they are promoting misinformation. So I think, David, maybe you can read this question and can continue to answer that.
Yeah, no, it's a really good point, and relates to that next question as well. So Twitter actually has made it much easier to access their data for academic researchers in the last year or so, last year or two. So actually they're moving in a very positive direction and working with academics to be able to do research that uses Twitter. It appears that Facebook is going the other direction. Other examples are not very open to accessing information. However, I actually don't think that so as I said, the work that we're doing now with these new tools to actually recruit people, number one, those study designs are much more powerful, but also we don't need access to their data because we can just ask people to record the data for us. And I think those are much more powerful studies anyway. And so while they have to be smaller in size and we can't access millions of posts at once, they might be just as useful and just as important. So the question was, how optimistic are you that social media would respond positively to improvement suggestions? social media engineered to maximize addiction and misinformation is simply very conducive to that end? The answer, yes. So David, yes, that this is part of it. I don't know that social media platforms necessarily have an obligation to do anything other than make money. And if we don't like them, we should just stop using them, but it's very hard to stop using them. I am generally, what's the right way of saying this? I don't think that social media companies, I don't think governments, I don't think researchers, I don't think anyone is actually as smart as we make them out to be. I actually think that they just have these, obvious bottom lines they're trying to do, and they're very good at optimizing for those. They're not doing anything nefarious. They're not doing anything bad. They're just doing whatever they need to do to make sense of the world and to make money in a lot of cases. But I also think that's kind of why being an academic is one of the most important professions in the world. We're one of the last groups of people who aren't around to make money. We're there to speak truth to power. And so being an academic is an important and privileged job, in my opinion. Okay, so we keep going, Adina. We've got a couple left. Yep.
Yes.
Okay, so a question from YK Lee was, how important are social media platform type preferences and functions for conducting and interpreting research on misinformation? For example, I worked in teams of Malaysian and Thai researchers, and putting the top 5 social media platforms side by side, we realized both countries consume social media on very different platforms. So again, we have to go back to the same answer again, which is I honestly think that the new work that we're doing right now with the team from University of Malaya is probably going to address these problems very directly. They're very different kinds of studies, but in my opinion, they're much more important, much more useful, and especially because we can connect that information diet from an individual to real outcomes, whether those are from electronic medical record or from questionnaires that they answer. Those are much more powerful, and I think they're going to help us identify risk signatures that could work in Thailand and in Malaysia and anywhere else as well. So Yong Kek Pang, may I know, how does the machine crawls through different social media platforms and retrieve the relevant information for the specific topics of research? So it depends on what we're looking at, and usually in very complicated ways. So what I hopefully mentioned briefly in the talk was the 2 software engineers that had been working on my teams for a long time. Paige Martin is a brilliant software engineer. She was working with us for quite a while, and then left to go to industry to make twice as much money as we could pay her. Well deserved. Jason Dalmazzo organizes it now for the kind of work that we do. It's different for each of the social media platforms, but also I think this is actually a really important question, because one of the studies that I mentioned at the start, a lot of the work that they were doing was they had access to data, and they were computer scientists, they were physicists. And they were like, oh, we have access to all this data. Let's answer a question that's related to vaccination or misinformation or whatever it is. And so they did. But what they didn't do was actually take a principled approach to try and understand what kind of question they're actually trying to answer, and fully integrate experts from health literacy, from communications, from social psychology, from public health, from epidemiology, into answering those questions. And so I think sometimes the questions that we want to answer actually require really sophisticated, difficult, challenging methods to try and crawl through the information that we need. So rather than just downloading 10 million tweets, which you could easily do, we need to think a little bit more carefully. And in our case, what we did was to look at the follower network. What we did was to think about how we could randomly sample from Twitter the users rather than the posts. And I think that if you start from that kind of approach where you're trying to answer a real question, then the methods that you need to use will appear. And if they don't appear, you have to find a different way. Last question. Is there any intervention or program that your team developed to reduce misinformation? Sadly, no. I would love to be able to do that. It would be very good if we could. And I'd love to be able to do more translational work in the space that we work in. However, I have to say, at the end of the day, I'm just a computer scientist at heart. I like to use data. Unfortunately, I run a department and have very little time to do any useful research. But I'm hoping that the kinds of things that we develop through this newest research that we're doing will be able to have really localized impact So people will be able to use the information that we produce to target their communication interventions very specifically at certain people on certain platforms. So for example, if we discover that people who use WhatsApp a lot and trust most of the information they see on WhatsApp happen to be more likely to not adhere to their statins, for example, then maybe the way to do that would be to advertise or to promote evidence-based medicine on WhatsApp, for example. And that's the kind of thing that we would like to be able to do with the work that we're doing right now.
All right. Thank you very much. I think there's another question on the or comment on the chat. Some people think that health misinformation should be dealt legally because it's almost something that's not supposed to be done. But then that will take time to change the legal system to look at how this can be done. What's your comment on that?
A very complicated area related to censorship. I actually think that if I was trying to solve the problem forever, I would do it through education at young ages. So earlier education about critical appraisal, and just creating safe environments for people to have their own communities and have healthy conversations.
All right. Thank you very much, Adam. It's 9. A lot of us has to go to clinic and wards and OT. So thank you very much for the time you spent with us this morning, enlightening us on misinformation. Thank you very much, everyone. Have a good day.
Thank you.
Okay, bye.